So yeah, good morning, afternoon, evening, everyone. My name is Ben Lee. Today we're going to uh, do a run through of contouring OARs correctly. And I know that the radiation therapist role is quite diverse around the world. So at some of you, it may be part of your responsibility to actually contour the organs at risk. Others of you maybe don't contour, but it's helpful to have an awareness because when you're doing your daily setups, you're keeping an eye on these to make sure that every treatment that we deliver is safe. And I want to start off with this question. This is actually, type your answer in the chat. So I'd like to see some responses just off the top of your head. Why does contouring OARs matter? I want to hear from your own words in your different regions. So type the answer in the chat, and then it could be fun. On the count of 3, everyone push send at the same time. So on your phones or on your computer, type your answer, and then don't click send until I count down to 3. Okay? So hopefully you have an answer in, and I'm going to count down now. 3, 2, 1, and everyone push send. Okay. Great. So we see some interesting answers. Do you see this, Divya, too?
Yes.
Okay, good. So for delivering dose correctly, evaluating the dose, determining how much dose we'll prescribe to a tumor, good insight. Reducing toxicity, great. Knowing which organs to avoid, great. So everyone is kind of hitting the main point that you achieve what you measure. And if you don't draw an OAR, you're not going to know how much dose it's getting. And as much as we like to rely on our eyes, oftentimes our eyes are not perfect. And so we need specific objective metrics to tell. So you need to contour it to know what's happening. And just a sort of illustration of why accuracy matters. When we actually get to the point of treatment planning, our dosimetrists or our physicists or our radiation oncologists are making decisions on whether to approve a plan or not based on how much dose it looks like is going to an OAR. And so this is an example of looking at dose measurements and objectives. And if it looks like it's good, then the plan will be approved. But if the OAR is drawn incorrectly, we could have a false sense of security, and what we see in our dose constraints could actually be wrong compared to what the reality is. And then this is just showing, how OARs might be drawn differently, which could lead to very different outcomes. So there are some tips for contouring OARs that are available online. This is a YouTube video that has a run through of contouring head and neck OARs, which I think Divya and I were talking about this just before the call, but I think these are the hardest. So this video is about 46 minutes, but it does a very specific run through of how to contour every OAR in the head and neck. Highly recommend it. We also have this video for how to contour the OARs in the thoracic region. And I highly recommend this for those that are doing breast cases or lung cases. This will show the specific OARs in the breast region. This one also shows how to do the contours. And as for this outline of the rest of the talk today, now that you have those two YouTube links, we're going to go over CNS OAR contouring, head and neck OAR contouring, thoracic OARs, abdominal OARs, and pelvic OARs. And I think the only OAR that I'm not going to talk about is skin, but skin is also an OAR. And just so everyone is on the same page, OAR is English for organ at risk. So for the CNS, these are the OARs that are important. Feel free to take a picture or note this down, or you might already have this. But the optic nerves, optic chiasm, pituitary, there's a pituitary gland and the pituitary stalk, the lens, the retina, which we often contour the whole eye as a surrogate for the retina, the lacrimal glands, the brainstem, and the cochlea. There's also the spinal cord, but I'll get into that during the head and neck. And I put stars next to the ones that are hard. And in particular, the optic chiasm, you often need the MRI to know exactly where it is, but I'll show a trick for how you can contour the optic chiasm with CT. So we're going to dive into a case now. Can you see my screen?
Yes.
Okay.
Yes, we can.
Great. So this is a case that had multiple brain metastases, and it was planned. And so you can see this is using SRS technique with multiple treatments. And then I have the OARs shown. First off, in the bony window is where you contour the cochlea. So this is the left cochlea, and this is the right cochlea. And I'm going to ask a question about this, so pay attention. How do I know that this is the cochlea and not this, or not this, or not this? You know, there are a lot of things that look all like they could be cochlea. So this is a typical window, and you see that I can't see the circles anymore. It's just white. So you always need to go to bone window when you contour the cochlea. The cochlea is always in front of the auditory canal. So that's the trick. So I adjust the window so I can see the bone. And then this is the auditory canal. It goes from the brainstem directly to the side. And it's the last canal you see when you're scrolling up. So if I start at the bottom and I scroll up, I see this. This is not the auditory canal. This is jugular foramen. And I scroll up more, and then you see this one. So this is the auditory canal, and then the circle in front of the auditory canal is the cochlea. So now let's see if you can see where it is on the right side. Here's the auditory canal, and so this should be the cochlea. Okay. So that is the cochlea, important for hearing preservation. And if there's one thing you remember from this lecture, I want you to know where the cochlea is. I've done my job if at least I've imparted that knowledge, but we're going to do more. So now let's go up. This is the eyeball, also known as the globe, and we contour the whole thing. And what we're really trying to protect is the retina, which lies in the back part of it here. But since eyes can move and even if the patient's looking left or right during treatment, that position can change. So we just contour the whole eye and we try to protect it. So the eyes are pretty easy to contour, pretty straightforward. If I turn off the structures, you can see this area that is less dark. So this is the lens. And then on the left eye, you can also see the lens. And does anyone know why, as we're looking at this case, it looks like, why don't I see the lens right here? Why does it look like the lens is at different heights on different sides of the patient?
I think there is rotation.
Excellent. That was Seguya Martin. So you're absolutely right. I chose this case because it's tricky and it illustrates that things are not always going to appear side by side when you're contouring your OARs if the patient is rotated. And so here we can see very challenging how the optic nerve comes from the left side higher up, and then lower down we see the optic nerve on the right side. So I'm going to talk about the optic nerves next. You want to correctly distinguish the optic nerve from the rectus muscles. So sometimes people get this mixed up with the optic nerve, but what is this? This is the inferior rectus muscle. You can see it on the sagittal view here. And what we actually want is to go to the midpoint of the eye. So your sagittal view can help reassure you that you're actually looking at the correct part. And then if you go too high, this is your superior rectus muscle. So you want to be in the middle of the eye, and then you contour this. And the take-home point for the optic nerve is that it always is going to pass through the optic canal. So you should always see a space where the nerve is able to make its way in. And when you see that space, you want to fill it in. And I fill it in just above and just below as well, because it's a three-dimensional structure. The slice thickness is finite, so there's going to be space in between. And the reason I want to get the optic nerve over to the other side is because on the other side is where it meets the optic chiasm. So even though on CT scan, you can't really see the optic chiasm very well, it always is going to connect to your optic nerves. And let's verify. Look at T1 MRI. And now you can actually see the structure here. You see this? This is the optic chiasm. So it correlates exactly with where optic nerves are coming in and entering the brainstem, or entering the brain. So, if you don't have an MRI, but you're contouring, let's say, a nasopharynx case that's high up, you'll want to get the chiasm to make sure you're protecting that. And this is how you can find it. So lastly, there's the pituitary stalk. The pituitary is always right behind the optic chiasm. The stalk appears bright and it goes down, and then the gland sits in the sella. So if I turn off the MRI, and if I were to draw the gland itself, so this stalk is behind right here. And then once it's getting down into the sella, which I can verify with my sagittal view, is where I will contour the gland, and it should be looking like kind of a flat pancake. And you just fill it up all the way until you get to the bottom. Okay. So now we have our pituitary, and this is actually a metastasis. So that's a hard place to have it. It'll be very important to have this pituitary contoured in order to spare that. Any questions so far?
Ben, we've just got a question in the chat.
Mhm.
So one of the questions is, in case a tumor is interfering with the normal anatomy, how would you know that this is due to patient rotation or tumor distortion of the anatomy?
If everything else looks like it's the same plane, but then you get down to the area where the tumor and now suddenly things don't look in the same plane, then you know it's distortion related to the tumor. So we'll see that with the head and neck case actually coming up. But if everything looks like it's off, then you know it's patient rotation.
Great. Also, I think there's some difficulty with some people hearing your volume. So if there's a possibility to increase your volume, it's clear for me, but I'm not sure for others. So if possible, could you just increase your volume?
Sure. Yeah, I'll try to speak a little bit louder. You can also increase the volume on your device. But great. And lastly, the brainstem. So I think with the brainstem, the biggest question is, where do I start and where do I stop? We call this Mickey Mouse ears. So you should see it looking like Mickey Mouse ears close to the top. And then I like to stop the brainstem when I get up to the ventricles. And you want to be consistent in how you're contouring. So so very quickly, this is going to be Ben's brainstem. And after this, we're going to move on to head and neck. So you see your Mickey Mouse ears. You can see the Mickey Mouse ears still a little bit. It takes a little bit of practice. I recommend, looking at an MRI if you have it, so you can practicing on those cases so you can make sure that what you see on CT is matching. And then up here, you start to see the ventricles. So here you can see the third ventricle clearly. It's this darker area. So right before I get to this third ventricle will be my last slice of brainstem. So see on this case, maybe even it was slightly under contoured, they wouldn't have been trying to spare it when they're treating this lesion. And then interpolating is helpful when you're contouring the brainstem. And then going the rest of the way down, I agree with these contours. I would spend a little bit more time, but just since we're in the lecture and I don't want to delay too much, but typically you contour every couple of slices. You can keep track in your sagittal and coronal views. That's another key point that hasn't been emphasized already, that anytime you're contouring, whether it's target or OARs, you want to keep an eye on your sagittal and coronal views. They can help orient you and make sure that what you're contouring makes sense in 3 dimensions. So the last question about the brainstem is, where do I stop? Because I could just keep going down for a really long time. But at some point, I'm going to get to the spinal cord. So I've turned off the other brainstem, so I'm not cheating. But you see here, I'm still seeing the medulla, the cerebellum. So I'll keep going down, and then here's where I'm going to start getting to the spinal cord. And so I think a good landmark is the top of C2 here, if you're using bony anatomy, or if you're just doing it on axial views, you go down to where you no longer see cerebellum in the back. And then on the MRI, you should be able to see on T2 sequence, the spinal cord and the inside will be bright. So starting to see hints of it right there, but that's where you get to the bottom, and then you interpolate and you have your brainstem. Okay, we're going to go back to the slideshow.
Ben, there's just a couple of questions
Sure.
in the chat. So Wajid Ali's got a question of, if the tumor touches the brainstem, like in the case of meningioma, what could we do?
Yeah, so always as a doctors, we will discuss this with a multidisciplinary team. I'll talk with the neurosurgeons, ask, does this seem like it's resectable or not? If it's compressing the brainstem and it's causing symptoms, usually we recommend resection if possible, because when we treat it with radiation, there usually is a risk of swelling in the acute phase, and that swelling could worsen the symptoms. If surgery is not possible, radiation is the only option. Then the doctors will decide what dose and fractionation they want to do to try to treat it. But your role as a therapist is to make sure that that brainstem is contoured accurately. Make sure you're distinguishing between tumor and brainstem there, because that's going to be critical. And you don't want them actually accidentally trying to protect the tumor or accidentally trying to treat the brainstem.
Very true, great. And we've just got one last question from Aubrey.
Mhm.
What is your technique if a tumor is very near the eye, and the trajectory of the beam, and the prescribed dose is 70 gray to the tumor?
So it sounds like we're talking about maybe a squamous cell cancer or a nasopharynx undifferentiated cancer. First and foremost, you need to treat the tumor. If the tumor grows there, it's going to lead to destruction that'll be much worse than what your radiation is causing. But if it's unavoidable, it's too close to the eyes, then you need to talk to the patient about what to expect from treatment, and you may need to consent them about the risk of blindness. Those are hard cases.
Okay, so we're going to show how to contour the optic nerves.
I want to show you
here.
this.
I'll start with the right
So
side.
you may need
The
to
main
turn up
thing
your
is
volume to here.
Make sure that you are in the center, the mid-plane of the eye. So I'm looking at the sagittal view here and seeing that it correlates here with somewhere in the middle of the eye, not to get confused with the rectus muscles that are on the edges of the eye. And once I'm in the middle, I see that it connects to the optic canal and goes through the optic canal. And I'll show you again on the other side how, as I scroll down, I see the optic canal and the optic nerve goes through there as I'm drawing it. And again, this should connect to the center of the eye on the sagittal view. And so now you'll see both of your optic nerves connected through the optic canal, and in the middle here is where we're going to draw the optic chiasm. And so the optic chiasm always, always, always connects to your optic nerves after they pass through the canal. So even on a CT scan where it's hard to see, you know that you're drawing the optic chiasm in the right place if it's connecting to your optic nerves. And I like to go up a slice to make sure that my optic chiasm is 2 slices thick, just to provide extra certainty that I'm protecting the optic chiasm. Okay, so we're going to show how to contour the optic.
As you saw at the end of this, the optic chiasm often looks like a cross. So when you're drawing on a CT scan, you should aim to have it look like this cross shape at the end. Okay. So key points, you should look at the sagittal view to make sure you've correctly identified the optic nerve at the mid-level of the eye. Make sure the optic nerve passes through the optic canal on both sides. And after the nerves pass through the canal, draw the optic chiasm, which is cross-shaped, so that it connects to the ends of both optic nerves. And then for the cochlea, let's see if you remember, we have a question here. So take a look at the picture, and then Divya, if you can wait just a few seconds before launching the poll.
Sure.
That way people can see the question. Which is the correct way to contour the cochlea? Is it this way, B, C, or D? And the brainstem is in the middle, just for reference. So you can go ahead and launch now, Divya.
Sure. Alrighty, so I've launched the poll, and so if everyone could answer their questions.
Good, and I want more than half of the people to get this right. That's my goal.
Looking good so far as they come through.
It's close. Okay. Maybe we can end the poll now.
Yeah, sure.
Okay. So we have the most popular vote as A, followed by B, then C, then D. which one is correct? A is the correct answer. So remember for the cochlea that you want to see the optic canal, and then the cochlea is always in front of the optic canal. Great. Head and neck OARs. So pharyngeal constrictors, parotid glands, submandibular glands, larynx, oral cavity, epiglottis, thyroid, and spinal cord. These are the OARs that we haven't talked about that we're going to go through here. So going to our next case. Whoa, okay. So this is a head and neck case. It's a T4, so very massive tumor involving the left side. You can see the tumor contoured in green, and then some of the other doses that we're going to be drawing are in red and in blue. And so if I hide my target contours, so we can see the normal anatomy. This is what we have. So this structure in pink is the oral cavity. It goes up to the hard palate. You can see really best on the sagittal view. It's including the tongue, as well as some of the space to the side, reaching the mandible on the lateral edges. And for contouring the oral cavity, this is explained in the YouTube video, which I posted, but it starts down as a little triangle. And then there's sorry, this isn't turning green. But it starts out as a little triangle down here where you start to see the texture of the tongue, and then it reaches anteriorly, and then laterally it's going to extend nearly to the edge of the mandible, and will keep going up until you get to the top like this, the roof of the mouth. A common mistake is accidentally contouring the soft palate here. So on the sagittal view, I can see that this part's hanging over. That's not part of the oral cavity. And here there's going to be a little bit of space in between the oral cavity contour and the airway. And then here you can also see air, so that's how you can see that. This red structure is the epiglottis, and when you're contouring the epiglottis, you want to go to lung window. That way you can actually see it. Otherwise, you'll only see an incomplete part of it on the standard window. We have the submandibular glands on the left and the right. Here you can see the distortion from the tumor. And this is very challenging. I think the submandibular gland could easily be contoured as part of this tumor on accident. So you remember, this is why lists are very important. You want to have a list of OARs that you're looking for. And you see on the right side here, it's like, okay, so there should be something on the opposite side somewhere. And so the radiation oncologist may be able to help with this. If you're ever unsure, ask a friend. Having a second pair of eyes is always helpful. But here you can see how the tumor has a different kind of density. It looks kind of heterogeneous. Some parts of it are darker than others, whereas the submandibular gland is kind of nice and innocent. And so ultimately we were able to determine it was right here. How about the parotid gland? So this is really tricky. The parotid gland starts higher up than the submandibular gland. It's going to be lateral, and the just keeping an eye on the right parotid gland, there's a sort of the outside lobe, which is easy to see, and then there's a deep lobe, which is difficult to see. So the main thing for the parotid gland is you want to make sure you always include the deep lobe. And I show this in the head and neck OAR contouring video, but the deep lobe reaches in towards the middle to reach the styloid process. So even if you don't see gland going over here, you always want to extend it until you get to the styloid process as you go up, and then just keep hugging the styloid process all the way until you get to the top where it finishes. And let's see, on the left side, I also see that the deep lobe is going to the styloid process medially. So that's the biggest mistake that I see with the parotid gland, is people forgetting to draw the deep lobe. Here you can see, we've contoured the brainstem again. We've contoured the pituitary, which sits here in the sella turcica. And then these are my cochlea, just sort of reinforcing this. And again, you can only see it if you go to bone window, but I see my auditory canal, and in front of the auditory canal is the cochlea. Hopefully I'm annoying you with how much I'm talking about the cochlea at this point. These are the temporal mandibular joints. So we actually contour this as a separate OAR to help prevent TMJ symptoms. There's no like super specific way to do this, but what we do is we contour the mandible, and then when we get up to the top here, right at the base of skull, again, bone window is helpful here to be able to see the outline. Just draw a little circle around it, maybe 2 or 3 millimeter perimeter, and that's the TMJ joint space. Again, that's this guy and this guy. The mandible does split when you're going higher up, but you continue contouring this as part of the mandible all the way to the top. These are the lips. For those that haven't seen the lips, it's kind of a funny one to draw because you can think of your own face as you're drawing it, but your lips aren't going to go up into your nose. So I look at the sagittal view, and you can see the texture is a little bit different. It's a little bit difficult to see, but it goes in front of the teeth, and that's all I'm going to say about the lips. And the larynx is this structure here. What can I say about the larynx that could be helpful for you? A common question is, for the larynx, do I contour the whole thing like this? So the difference here is that this is including the bone. Do not do that. The larynx is the cartilaginous part, or the mucosal part that sits behind the bone. Where does the larynx start superiorly? It starts when you start to see the bone. So that's pretty straightforward. When you start to see the bone, that's when you start to draw the larynx. And then where does the larynx end? It ends after you get to the bottom of the cricoid cartilage. So the cartilage is sort of this white, and then you can no longer see white, so you're at the bottom. So I know I'm making this sound kind of easy, but that's my goal. And so larynx, you can see on the sagittal view, it should look something like this shape when you are done. And I think the only structure that we have left is the pharyngeal constrictors. Let's see if this cooperates for me. And then after I draw this, I'll pause for some questions. Okay, great. So the constrictor muscles start at the top, at the base of the skull. I'm going to make my brush just a tiny bit smaller. And these are muscles for swallowing. They're not just in the back, they do extend here to the side. So, I mean, even in this case, I think this is part of it. These constrictor muscles actually might be new if you're transitioning to IMRT, because we used to not be able to spare this when we were doing our planning. It was very hard to spare midline structures with 3D conformal radiation. But now if you're doing IMRT and you have the ability to spare midline structures, you want to be drawing your constrictor muscles. Doing so will help protect your patients and preserve their ability for swallowing, which is very important during treatment so that they can continue to eat what they need to do, maintain their weight, keep their strength, and continue showing up to complete all of the treatment. And then afterwards, you want to prevent fibrosis of the muscles so that they don't have any life-changing side effects. So this is how you contour the constrictors. And similarly, I go just every couple of slices, we'll contour this. And then eventually it's going to meet the esophagus at the bottom. Okay. I'm taking time to go through this one completely because I think this might be a new one for some of you. So here's the esophagus. The esophagus starts at the bottom of the cricoid cartilage, or basically where this thing starts to get plumper and more round, whereas the constrictors are more flat and pancake-like. And so here I can see sagittal. I'm going to interpolate. And now I have a pretty good set of constrictors. Good. And then when I'm scrolling through, I would polish any areas that look like they still need some fixing. After you interpolate, even for OARs, you always want to scroll through and check and make sure that you're not missing anything. Okay, great. I think I'm burning through my time.
There's a couple of questions in the chat, Ben. One of them is the tolerance for organs at risk changed if the patient is treated with hyperfractionation? And if so, is there tables or charts for these dose tolerances if treated with
Yes.
hyperfractionation?
Yes. The OAR dose constraints should be different if you're using hypofractionation. General, if I'm treating in less fractions, let's say for the optics, for instance, if I was treating conventional fractionation, I want a Dmax of 55. If I'm treating in just one fraction, I might want a Dmax of 10 gray. So you can see how the dose limit changes when you're hyperfractionating. Just exactly what should it be? That's kind of another topic, but there are tables for fractionations between 1 and 5. The TG 101 report has basically a list of dose constraints. For moderate hyperfractionation, you may want to look at specific protocols that those studies used, which the radiation oncologist should hopefully be able to access. This is a video that you'll have in the PowerPoint, which just shows kind of what I was talking about with the parotid gland.
I'm going to start on the left side.
And
you can see that it's in this example,
kind of from
it's
beginning
next
to end, how I start at the
submandibular
bottom
part is pretty
and
easy
then work
because
my
you
way
can see
up.
the gray, how it's pretty well defined. But the tricky part of the parotid gland is that there's a deep lobe, also known as the median lobe. And this is the part that a lot of people miss when they're drawing the parotid gland. So you see that I'm following the gray as I'm going up little by little. And once I see this bone, that white part, that's where I need to draw the parotid gland extending out to. That's the styloid process, and that marks the edge of the deep lobe of the parotid gland. So
okay, so hopefully that's a take-home point. So
okay, so now we're going.
Here's a question. Which of the following is the correct way to draw the parotid gland? So hopefully set you up for this, set you up for success. Take a look at your screen while you can see it. Is it A, B, C, or D? And Divya, I think ready if you want to launch it.
Sure. Should be coming through there.
Great. Well, I'm very happy with these responses.
You set them up for success for sure.
Yeah, that's the goal. I'm here so that you guys can treat patients better to your best ability. We're all constantly improving, and I'm honored to be just a small part of that journey for you. Okay, I think we can go ahead and end the poll.
Sure.
Okay,
There we have it.
so everyone see this? So the answer was C. And why is the answer C? It's because it's extending, it's including the deep lobe, extending to the tip of the styloid process. So that is perfect. Good job, everyone. So,
There's a couple of more questions in the chat, Ben. Do you want to just take them after?
oh yeah, go ahead.
Okay.
So,
Let me scroll up to where they were. Amna's got the questions asking, can you share the contour while the patient is not swallowing? I'm assuming that in relation to the changes with and without swallowing and how you account for them, possibly.
what's the question again?
The question is, can you share the contour while the patient is not swallowing? I'm not sure if you want to unmute and elaborate on that, or we can come back to that later.
Oh, maybe is there a contour I can show when the patient is not swallowing? No, sorry, I think when so one thing it can change is the larynx during diagnostic scans. Skilled technologists will instruct the patient to sort of activate their vocal cords a certain way or not. But that's a little out of the scope of this. Sorry. One thing I actually wanted to mention is the parotid gland has a tail along the upper outside edge. And so I sort of skipped that, but here I want you to pay attention to this.
Now it's interpolated,
this
and
part.
you can scroll down.
Up here. So you keep an eye out for a pointy part of the parotid gland that will extend forward here. This is called the parotid tail. And so now the submandibular gland, this is just a series of pictures showing it. I think if you identify the submandibular gland at the bottom, you should be okay. As you work your way up, you can continue following it. Notice that it's going to end up here at the back inside part of the mandible. So that's kind of a key landmark to keep track of, because there are other things that can mimic the submandibular gland. We have a question now. Which of the following is the correct way to draw the submandibular gland? So hopefully I've set you up for success as well.
I will go ahead and launch that poll. It'll be coming through shortly. There it is.
This is checking to see if you heard my last thing. Okay.
Yeah.
This one's a bit tricky because it's just a single axial slice. But we'll go ahead and end this.
And those are the results.
Okay, so no one thinks it's D. I think that's great. So now it's just between A, B, or C. A is incorrect because it's the outside of the mandible. The parotid, or the submandibular gland, starts below the mandible, submandibular, And then as it works its way up, it's going to be on the inside edge of the mandible. So it's going to be B or C. And as I just mentioned, it actually ends at the posterior inside edge of the mandible. So B is correct. Now, how about larynx? So which of the following is the correct way to contour the larynx? Is it A, where it includes the bone and the cartilage? Is it B, where you draw halfway through the bone and the cartilage? Or is it C, where you exclude the bone and the cartilage? Or is it D, there's no published consensus guidelines?
I will go ahead and launch that poll. It's becoming true now.
Okay. So I I jumped the gun and I shared the answer, but you guys had it. So the answer is C. 80% had that correct, so great job. You want to exclude the bone and the cartilage. Thoracic OARs, so I'm going to go through these quickly. There's the esophagus, the heart, the LAD or left anterior descending artery, brachial plexus, lungs, spinal cord. So if there's time, I will talk about each of those. I may only have time to really emphasize the heart and the LAD though. So this is a post-mastectomy breast case. We're treating the chest wall and the regional nodes. And I want to show you as you're getting into IMRT and maybe doing more sophisticated treatments, but the heart has substructures. So the heart is here in pink. The heart has a defined border superiorly. And then it ends at the bottom where you get to the bottom of the pericardium. So this dark gray stuff is still pericardium. The heart has something called LAD or left anterior descending artery. And once you know how to look for the LAD, you'll never miss it again. So I'm going to show the LAD is always here in between your left ventricle and your right ventricle. And the LAD goes all the way down to the bottom of the heart. You may not be able to see the LAD on every slice, but you just have to have faith that it does make its way down to the bottom. So if there's a slice that you can't see it, that's okay. Just skip it, and at the end you'll interpolate. The top of the LAD, it's going to start to get long like this as it's going sideways. Hopefully you can see this. And then at some point it stops. And so when I'm defining the top slice of the heart, the top slice of the heart should be where you last have the LAD. So in this case, this heart is over contoured, and I would delete this slice. And I would delete this slice. And delete this slice. So when experts are reviewing heart contours, this is what they're looking for the heart. They're trying, the reason that protecting the heart historically has been so important probably is a lot related to this LAD. We just didn't know that the LAD was specifically drawn here. We weren't contouring it, but if you spare the LAD, you prevent a lot of heart toxicity. So any questions about heart or LAD?
Then there's a couple of questions in the chat about LAD, what it stands for and a bit about it.
Okay. LAD stands for left anterior descending artery. It's possibly one of the most important arteries that actually supplies the heart. So if that artery gets radiation, becomes atherosclerotic, the heart is going to suffer and not be perfused as well. So it's kind of like the heart's own blood supply. Does that answer your question?
Yes.
And there's also a question about what's the tolerance for the LAD?
Good question. So let me see if I can pull this up here. When we are doing moderate hypofractionation, so treating in 15 or 16 fractions, our LAD should have less than 1% be 15 gray. So essentially a Dmax of 15 gray. And when you're doing ultra hypofractionation, you want it to be even stricter. So maybe less than 1% covered by 12 gray. This is in contrast to the heart mean dose constraints, where typically you're trying to get a heart mean dose of less than 3 gray, less than 2 gray if possible, sort of depending if it's a left or right-sided heart case. Okay, other things that I can show here, the esophagus. So the esophagus might become very skinny and squished as you're going up. It might be hard to see, but whenever you see a little bit of air, it's a clue that your esophagus is there. Sometimes I will contour just on the slices where I can see it well, and then I'll interpolate. And then it goes up to where you get to the bottom of the cricoid cartilage. The lungs, pretty self-explanatory. I have the spinal cord drawn here. And then you will want to contour the liver if it's a heart case where the dose is going down to the level of the liver. Similarly, if it was going down to the level of the stomach, you would want to contour the stomach as well. Great. So this is one of the last Zoom poll questions. Which of the following is the correct way to contour the esophagus? Is it A, B, C, or D?
Just want the poll there, so go ahead and input your responses.
Mm-hmm. And by the way, if you're on your phone and you can't see the picture, click close on the poll, and then you should be able to see it. Then once you've studied the answer, you can go back to the bottom and click on the menu where it brings up the poll. So you can see the poll again, and then you can answer. Okay. Interesting.
Hmm. We've got a few
I'm
more
glad
coming in.
glad we asked this question.
It's a great question.
Okay. We're going to end the poll and then talk about this. So, the correct answer, it looks like a pretty even split. People were choosing between A, B, or C. D didn't get a lot of love. The correct answer is C. And this is really, really important. So I mentioned that air can help us see where the esophagus is, but air does not define the entire esophagus. So in this case, C is the correct answer, and you can see that A is missing this whole part of the esophagus. So the esophagus is squishy. It's a squishy tube. Sometimes you can see air through the tube, sometimes you can't, but we want to cover the whole tube. So here's some other examples of how the esophagus is squishy. It's not always going to look like a smooth circle. And here you can see a part that has air. You don't just contour the part around the air, but you want to contour all of its squishiness. And if you go from top to bottom, sort of working your way down, you should be able to see how the squishiness changes gradually as it's going down. I have a link here where you can explore more. The other key point about the esophagus is that we've seen this. You draw it and then you interpolate, but you have to make sure you scroll down because the esophagus can kind of wiggle from side to side as it's going down. And you don't want to accidentally have the esophagus interpolated and here in the middle of the trachea. So you want to make sure that the esophagus is accurate from top to bottom. So key points about thoracic, the LAD is important for left-sided heart cases in particular, where a dose could get to that spot. I didn't talk about the brachial plexus, but you contour this when the target is near the brachial plexus to avoid having a hot spot on the nerve. Interestingly, we contour this for when we're treating heart cases, or when we're treating breast cancer patients. When we're treating head and neck cancer patients, typically you don't need to contour the brachial plexus in the upfront setting where you're treating them with radiation the first time. But if it's a recurrence and you're treating them for a second time, then you really, really need to be careful about the brachial plexus. And we always will contour the brachial plexus if the target is near that in the setting of reirradiation. The lungs, you want to contour completely from top to bottom. Why is this important? Why don't I just contour the part that's close to the target? It's because our dose constraint for the lungs is a mean dose constraint or a volumetric dose constraint. And we need to know the entire volume of the lungs in order to get an accurate reading with that. I didn't talk the chest wall, may not be kind of in the scope of this, but if you're doing an SBR treatment near the periphery of the lung, or the tumor's near the chest wall, then we contour the chest wall as OAR. Abdominal OARs, there's not enough time to go through these. I will say that the trickiest thing is distinguishing a large bowel from the small bowel, and then in the case that you have liver SBRT case, here I'm going to critique this just a little bit. So we can see where the target is, where we're doing the dose. what did they not do here that they should have done? Well, dose is going to be coming from all directions. So you want to make sure that bowel is covered on the slices where there's going to be dose. So here they contoured the duodenum, but the duodenum should also be contoured here superiorly. So this is really important when you're doing bowel. I know it can be tedious because there's so much of it to contour, but if it's on the same level as the target that you're contouring, you generally want to contour the bowel. And then lower down, you don't need to contour everything that's way lower than your target. So that can save you some time. The kidney, you should use a little bit of polishing here. So if I were to make a correction, just want to make sure that you're being complete. And then the liver, you want to think in 3D. So as you're going down, keep track of the front part as well as the back part so that you're continuing to include it as you go down so you can get an accurate volume of the liver. And then the stomach is here, connects to the esophagus. And as the stomach goes down, eventually it's connecting to the small bowel. So this is where stomach would end. And then this is where small bowel would begin. And then the duodenum is this next portion here. Okay. I'm sorry I don't have enough time to go through the distinction between small bowel and large bowel. Maybe I'll make a video about that later.
Then
We're
there was
almost
just a
there.
question in the chat. Is now a good time or at the end? I'm just
Sure,
mindful of time.
sure, we can take this.
Oh yeah. Aaron's got a question on what's your take on contrast agents?
It's about timing. So I don't have particular advice about which agent to use, but when to use contrast. Contrast can help you see the loops of bowel, which can help you distinguish it from tumor. So that's really helpful in pancreas cases, where the pancreas is so fuzzy and hazy, and it can really blend with the bowel. So you can instruct your patient to take oral contrast before CT simulation. It could also be helpful if you want with your liver SBRT, although if you're experienced, that's not always necessary. For rectal cancer, it can be helpful down at the bottom to be able to see more clearly where is the tumor. If that's optional, but if you do that, you need to take the contrast agent more in advance so that has time to transit all the way through the body and reach the rectum by the time you do the CT scan. Any other questions about GI? Share tips of contouring the duodenum. You want to go from top to bottom as you're scrolling up and down. So if I was following the duodenum, let's say I'm following it here. I'm scrolling down. I want to make sure I'm continuous. So actually here I would And by the way, this is small bowel, so this should be contoured, but the small bowel snakes back and forth, so it's not part of the duodenum segment. But you can see as I'm scrolling up and down, I'm making sure that what I have is continuous. You don't want any specks of gray left unlabeled. And then, well, what happened here? So, this is tricky. So I think it's going here posteriorly, and then now it's here, and then continuing down. The duodenum continues to go down until it gets to the bottom of the pancreas. Then it'll go to jejunum, which goes sideways, kind of underneath the pancreas, and then so this is the main part of the duodenum that you're contouring. Just make sure that this part here is still labeled as small bowel. This was kind of a weird example, I'm sorry, but I hope that's a little bit helpful. Okay. So in the last 8 minutes, pelvic OARs, very important for cervical cancer cases. The main thing is the rectum. You want to make sure that you don't mix up the rectum with your tumor, and that you don't mix up the rectum with the vagina. It's important to distinguish the tumor from rectum, and if you're not sure, ask for help. The rectum starts at the bottom of the ischial tuberosities, and then it transitions to sigmoid when it starts to move forward anteriorly. So here's a cervical cancer case. You can see it was planned very nicely with VMAT. There's some, I'll turn off the dose here. And then the rectum is here. And I said it starts at the bottom of the ischial tuberosities. So those are these bones. So it would start here. And if you see gas, that's part of the rectum. So that's one clue. And then here, really important to distinguish this from the vagina, which is right here. You can see a thin layer of fat space separating the rectum and the vagina here. And then here, this is what I'm talking about, where you want to make sure that you're not confusing, that you're not accidentally contouring all of this as rectum. That would be very bad. So don't do this. Okay. Rectum takes practice. Not enough that I can share in just a single lecture. But at some point when you're scrolling up, the rectum will begin to go anterior, and when it goes anterior, it becomes it starts to go into the large bowel. So I mean, so we also had the bladder, this yellow structure here. hopefully you guys all have that. And then this is small bowel. And then this over here on the right, this is always going to be large bowel. So if you remember that picture, you have the small bowel goes into the corner, this bottom patient's bottom right pocket, usually here, and then you have the appendix, and then there's going to be large bowel that goes up. So here's large bowel, the ascending colon, and then you have the transverse colon where it's going sideways, and then eventually sorry, here, and then you have the descending colon, which is going down on the left side of the patient. And then this descending colon should eventually make it and connect to your rectum if you follow it. So this is a sigmoid, and then the sigmoid's made it to the rectum. Okay. Hopefully this is, this whirlwind fly through of all the OARs is some of the key points are hitting home. If you're doing prostate SBRT, you need to contour the urethra. If you're doing that and you have questions, feel free to contact me. Don't have time to go through that in this lecture. This is a very, very helpful reference for you, everyone. This is econtour.org. This has cases across all disease sites. You can see the OARs. You can also see different anatomy and target structures and what they look like. Highly recommend this if you have not used it. The account is free. So please visit econtour.org if you are someone that contours. Like every radiation oncologist in the United States has this and uses this. This is also a way to practice contouring. So this is chronosystems.com/contouring. You should be able to make a free account, and you can practice contouring and then get feedback. Get a score of how well your contour is according to what's correct. And these are some of the OARs that you can practice there. So I recommend that. Practice makes perfect. And we've covered all the key points, in my opinion, for CNS OARs, head and neck, thoracic, abdominal, and pelvic. Quality of contouring OARs makes a big difference on patient outcomes. Be able to recognize common mistakes, that way you can avoid them. And then this lecture is just the beginning of your learning journey, but there are a lot of videos and resources from this lecture that you can use to continue improving. And I hope that you can teach and share what you've learned from this with others. Next week, we'll be having our speaker, who's a radiation therapist educator, on how does RTT workflow change when using IMRT. And with that, I would like to thank you all for joining.
Thanks so much for your time, Ben. It's been great, and definitely I've learned plenty of new things, so I'm sure the rest of us have as well. Do you have time now to take some questions, or would you like the cohort to just email them through?
Yeah, I'm happy to stay on. Usually there's,
We can just take a couple. And just
Yeah,
mindful
yeah.
of time and things as well.
Yeah, I hope this was helpful. I felt like it was kind of hard to go
For
through all of
sure.
the OERs in just one session, but I really just tried to hit home the most important things where people mess up.
For sure, yeah. I'll just go up to, since we covered pelvis OARs last, we've got a question on should we be concerned of the volume of gas in the rectum during stimulation considering the fact that the volume of air can change during treatment, and what your take on this?
Yeah, so this comes up a lot in prostate cases or cervical cancer cases. You want to try to simulate with an empty rectum where you don't have a gas bubble. Why is that? It's so that you can reproduce that. It's easier to reproduce an empty rectum than it is to reproduce a random gas bubble. Whatever you simulate, that's what they're going to draw and contour and do their plan on. And then if the position is different on the day of treatment, then you're going to be delivering either too much dose to the rectum or not enough dose to the target. So what we do, if we see a gas bubble, we can ask the patient to go to the bathroom before simulation. Or I mean, they've come for simulation, you do the scan, you see a big gas bubble, ask them to go to the bathroom, and then you can try again. If they said, Doc, I've already gone to the bathroom 6 times, I can't go anymore, then you can insert a little rubber tube into through the anus, and then that will sort of help get the air out. And you should hear a noise which sounds like farting, which tells you that the gas has come out.
Great. Just one last question. Where was it? Let me just scroll up. Is it important to differentiate between the anal canal and the rectum, as they may have different dose tolerances?
Yeah, nice question, Gordon. We don't differentiate between the two. We just contour the rectum. The anal canal is likely more resilient. Muscles tend to be more resilient to radiation treatment. So if you're meeting rectal dose constraints, you're certainly kind of protecting the anal muscles.
All right, great. That is, I think I'm just mindful of time. So I've popped the email in our chat. So if anyone's got any extra questions, to feel free to email through, and the team will get back to you on any of the questions or concerns that you guys have, or anything that was out of scope of today's session. Send through all your questions to that email.
Oh yeah, I should share my email address. Okay.
I put the training one in.
Oh, perfect. That's great.
Yeah.
And then my personal email is here. ben@rioscontracancer.org. Thank you all so much for joining. I really hope that you guys have a good day, good night, and that we'll see you next week.
Perfect. Yeah, and again, once again, thanks, Ben. It's been definitely informative, and I think we've all taken something away from it, especially just learning the importance of delineating all these organs at risk and their junctions and where they cross over into different organs. Definitely been useful, and thank you everybody else for jumping on the call, and we look forward to seeing you guys on our next session, as Ben mentioned, which will cover how the radiation therapy workflow changes when using IMRT.
Wonderful. And I'll just post those YouTube links again here, so that you guys have them. Divya, really, thank you so much for joining and moderating. We had a great time with you. I hope to see you some more.
My pleasure. Yeah, definitely. Likewise.
Yeah, thanks for staying up late in Australia. And then here are the 2 YouTube links, one for head and neck, and then one for breast and thoracic. And with that, I will see you all later.
Alrighty. Thanks, everybody.
Hey.
Thanks so much, Ben. Take
Hey,
care.
bye-bye.
Bye.
Bye-bye.
Bye-bye.
Goodbye.
Bye.